Hi guys, it's Dawn and today we're going to talk about PRVC, also known as pressure regulated ventilation. Today with our learning objectives, we are going to be defining PRVC ventilation, learning the mechanism of action, discovering the history of PRVC, recognizing the indications for PRVC, examine the settings and parameters, the benefits and limitations, and examine various PRVC waveforms that can help us determine how the patient's doing. In a world of mechanical ventilation, precision is paramount. But what if we could ensure that the best of both worlds, pressure and volume, are always in perfect harmony? Enters PRVC, or pressure regulated volume control, a mode that doesn't just focus on one variable but adapts dynamically to deliver the optimum balance for the patient's respiratory needs. Defining PRVC. It's a hybrid mode of mechanical ventilation that combines the benefits of volume control and pressure control. The volume ensures a consistent tidal volume. The pressure regulation limits the airway pressure to prevent lung injury. It's a smart ventilation mode that combines the features of both volume control and pressure control ventilation. The goal of PRVC is to deliver a set tidal volume while keeping the airway pressure within a safe and optimal range. Pressure regulated ventilation has been developed to ensure safe and effective ventilation for patients' needs, where the ventilator adjusts inspiratory pressure to deliver the target tidal volume while minimizing the risk of lung injury by combining volume and pressure control ventilation. In short, PRVC adapts to the patient's needs, delivering a precise tidal volume while avoiding high pressures that could harm the lungs. It makes it very helpful in patients that have variable lung compliances. Mechanisms of action. Set target tidal volume. The ventilator is set to deliver a preset tidal volume similar to traditional volume control ventilation. Dynamic pressure regulations. Unlike standard volume control, where the ventilator uses a set volume, PRVC dynamically adjusts the inspiratory pressure to achieve the target volume. The ventilator measures the patient's lung compliance and resistance. If the lung compliance is reduced, the ventilator will increase the pressure to deliver the desired volume. If the compliance improves, the pressure will decrease. Pressure limitations. The ventilator ensures that the airway pressure does not exceed the preset pressure limit. Adaptive feedback. The ventilator adjusts the inspiratory pressure for subsequent breaths to ensure that the tidal volume is met. Now let's get into the history of mechanical ventilation, which led us to PRVC. So mechanical ventilation has evolved over the decades with the primary goal of providing controlled breaths to patients who cannot breathe independently. This was around the 1960s and 1980s, where the methods relied heavily on either volume or pressure control ventilation. Around the 1990s to 2000s, the idea to solve a common challenge, which was the need to maintain a precise tidal volume while protecting lungs from excessive pressure, was developed by Dr. Thomas E. Ginn and his colleagues at Draeger Medical, who were accredited with the development of PRVC. His work was instrumental in designing ventilators that could perform PRVC. The first ventilator to use PRVC was by none other than Draeger, the Avita Series 2, which I have pictured here below. I've never worked with any Draegers, but they look kind of cool. The microprocessor. The microprocessor plays a crucial role in PRVC by continuously monitoring the patient's breathing pattern and adjusting the inspiratory pressure to deliver the set tidal volume with the lowest possible pressure. It serves as the brain of the ventilator, optimizing the patient's breathing while preventing harm. Microprocessors are central to PRVC success because they enable real-time adjustments with precise control, continuously safely monitoring, and efficient patient ventilator synchrony and data analysis in storage. That way, us, the providers, we do not have to keep running back to the ventilator and making adjustments to help the patient. Now, let's talk about the indications for PRVC. We'll start with acute respiratory distress syndrome, which is characterized by decreased lung compliance requiring careful management of ventilation to prevent barotrauma or volume trauma. Acute lung injury, which is similar to ours but not as severe. Variable lung compliances. These patients whose lung compliance changes dynamically, or those recovering from surgery, or those who have conditions like pulmonary edema or fibrosis. Thoracic or abdominal surgery. These patients may have decreased lung compliance or increased airway resistance. Patients that have obstructive lung diseases such as asthma or COPD, the airway resistance, which is due to the bronchoconstrictions that the patients can be having. Patients that have obesity, hypoventilation. This can lead to a restricted lung compliance and difficulty in maintaining adequate tidal volumes. These are the settings and parameters for PRVC. We want to keep our tidal volumes between 6 to 8 mLs per kg of ideal body weight, respiratory rate between 10 and 20, our TR I to E between 1 to 2 or 1 to 3. We want to keep our peak between 5 and 10 since we are trying to make sure that we don't have any type of pressure issues. Our pressure limit is going to be between 30 and 40, so anything above that, then we're having a serious problem. We want to have our flow rate between 40 and 60 liters per minute. Our trigger sensitivity is either going to be between -1 and -2 for pressure and 2 to 5 liters per minute for flow. And our inspiratory pressure is going to be between 10 and 30 centimeters for water. Now let's talk about the benefits of PRVC. Consistent tidal volume, which PRVC helps to ensure is delivered to the patient, even if the patient's lung compliance or resistance changes over time. Pressure limitations for lung protection. PRVC is aligned with lung protective strategies that use low tidal volumes, which are recommended in conditions like ARDS. Also, it reduces the need of mechanical adjustments in settings as the ventilator responds to the changes in the patient's condition. Patient comfort and synchrony. PRVC is going to minimize the flow of airway fluctuations that minimize discomfort that can arise from the excessive pressures. It also is going to help with our work of breathing. The ventilator automatically adjusts the inspiratory pressure based on the patient's lung compliance, which ensures the tidal volume is delivered while reducing the work of breathing. It also lowers the risk of hyperinflation, which PRVC helps to avoid over-ventilating and under-ventilating the patient, which can cause discomfort due to the fluctuating CO2. By delivering the right volume at an appropriate pressure, we're going to maintain a normal blood gas level, which improves the patient's comfort and reducing symptoms like shortness of breath. Improved oxygenation. One of the primary advantages of PRVC is the ability to optimize oxygenation while minimizing the risk of barotrauma or volume trauma. This adaptability helps maintain adequate ventilation in patients with fluctuating respiratory conditions. Flexibility across patients' conditions. PRVC has versatility across a wide range of patient conditions makes it one of its standout features, whether the patient presents with acute respiratory failure, chronic obstructive pulmonary disease or COPD, neuromuscular disorders, or postoperative respiratory support. PRVC is designed with sophisticated monitoring and feedback mechanism, which allow real-time data assessment to guide clinical decisions. The ventilator continuously monitors the tidal volume delivered, airway pressure, and patient's respiratory rate, providing crucial feedback that informs adjustments in ventilator settings. Now let's talk about the disadvantages and limitations of PRVC. It may be inadequate in severe airway obstruction patients. Those with severe airway obstructions would not be ideal because PRVC would have difficulty maintaining the target tidal volume, such as ARDS, asthma, and COPD patients. The ventilator may reach its maximum pressure before the desired tidal volume is delivered, making it difficult to maintain volume control. PRVC may not be ideal for very low lung compliance patients. Inconsistent ventilation and spontaneously breathing patients. The ventilator may have difficulty synchronizing with the patient's breath. If the patient breathing changes rapidly, the ventilator might struggle to maintain the target tidal volume. Or if the patient may feel uncomfortable with the pressure changes being so unpredictable. Sudden changes in lung compliance can lead to inappropriate pressure adjustment. This, we have the risk of barrel trauma or volume trauma. Even though PRVC helps to limit excessive pressure, barrel trauma and volume trauma can still occur if the preset pressure is too high or if the tidal volumes are not optimized for the patient. In these cases, you're going to flip the patient back to a more traditional mode like a volume control, or in this case, it would be a pressure control. Here are the waveforms that we use to monitor patients when they are in PRVC. So we have the pressure time waveform, the volume time waveform, and the flow time waveform. And by looking at your waveforms, you can tell how your patient's doing. If your patient has a sudden pressure spike, it could be that it indicates that there is an abrupt increase in airway resistance or changes in lung compliance. It could be secretions, bronchospasms, or the ET tube could be kinked. Your patient could be coughing or moving, which could cause a sudden increase in pressure. If there is a sudden increase in pressure, what should you do? We're going to treat it like an obstruction and we're going to suction. Now, if that doesn't help us when we suction the patient, then you may need to remove your patient's ET tube and manually bag them. Inconsistent volume waveforms. It could mean that the tidal volume delivered by the ventilator is variable from breath to breath, or the volume may not match the expected set tidal volume. Now, this could indicate several problems. We could have variable lung compliance, patients with pulmonary edema, ARDS, or COPD, patient effort or asynchrony. The patient might be trying to breathe on their own. Ventilator miscalibration. This is very rare, but sometimes we do have ventilator calibration issues, which could lead to inconsistent volume delivery. Now, if you're looking at your waveform and your flow does not return to baseline, it could mean that your expiration flow curve is not zeroed out after the inspiratory phase. Again, we could have another airway obstruction, increased expiratory resistance, like bronchoconstriction or a patient that has COPD. You could have some auto PEEP going on, which means that there is some PEEP still remaining in your patient's lungs. Now, if you notice any of these waveform irregularities frequently, a deeper assessment of your patient is really needed. Okay? In conclusion, PRVC ventilation is an advanced mode of mechanical ventilation that combines the benefits of both volume control and pressure control modes. The microprocessor acting as the ventilator brains, adapting to the patient's needs while improving patient comfort and minimizing the risk of lung injury for patients with ALI and ARDS. Now, we also learned that sometimes PRVC is not the best mode for some of these patients. For patients with severe obstructive diseases, it's not really going to benefit them at all. They might benefit more from pressure control. Thank you for listening to my presentation. And here are the resources. Have a good day.